بسم الله الرحمن الرحيم. هنبتدي السيشن اللي جايه. دكتوره لبنى، OCT in diabetic retinopathy retinal ischemic cascade. اتفضلي يا فندم.
نبتدي يا جماعه. بسم الله الرحمن الرحيم. My second talk is OCT biomarkers. The normal retina has a regular and distinct organization of the retinal layers, which must be preserved, present and functional in order for the visual process to occur normally. On this normal OCT scan, all the layers are distinctly visible and uninterrupted. They are from inside inward. احنا ما عندناش pointer او مفيش pointer او cursor على ابتدي من الاول، بس انا محتاجه pointer. من فين؟ لا انا مش عايزه كده، انا عايزه اشاور على حاجه. اشاور على مش شغال. طب ماشي خلاص. اوكي مش مشكله. The normal retina has a regular and distinct organization. Of the retinal layers, which all must be present and functional in order for the visual process to occur normally. On this normal OCT, all the layers are distinctly visible and uninterrupted. They are from inside outward: nerve fiber layer, ganglion cell layer, inner plexiform, inner nuclear layer, outer plexiform, outer nuclear layer, and external limiting membrane. Four distinct hyperreflective lines are seen in the outer retinal layers of the OCT scan on a healthy eye. These four hyperreflective lines should always be identified when evaluating a macular scan. From inside outward, we have the external limiting membrane, IS-OS junction or the ellipsoid zone, coast or the intervegetation zone, and the RPE. OCT biomarkers. A biomarker means morphological and structural alteration that can provide important information about the stage of the disease. OCT allows to identify specific retinal biomarkers associated with visual acuity and provide information about the patient visual recovery after anti-VEGF treatment. OCT biomarkers in diabetic retinopathy. Diabetic retinopathy is one of the major microvascular complications of diabetes mellitus. The most common cause of vision loss in diabetic retinopathy are diabetic macular edema and proliferative diabetic retinopathy. Recent development in ocular imaging have played a significant role in screening eyes of diabetic patients, monitoring its progression and response to treatment. So our aim is to highlight some OCT imaging biomarker that can have a potential contribution in diabetic retinopathy management. First, we have the hyperreflective retinal foci. Represent subclinical lipoprotein that extravasate after breakdown of the inner blood retinal barrier. Present in the inner retinal layer, then migrate to the outer retinal layer. Size more than 30 micron with absence of backshadowing. They are important imaging marker for retinal inflammation. Its size and number may decrease after treatment with anti-VEGF or steroid. Some studies found that initial presentation of a large number of hyperreflective retinal foci responded better to steroid than anti-VEGF. Hyperreflective choroidal foci. It is believed that hyperreflective choroidal foci has migrated from the retina to the choroidal layers with disruption of the external limiting membrane or ellipsoid zone. Its presence is a poor prognostic marker in the term of visual acuity. Hyperreflective choroidal foci significantly more in proliferative diabetic retinopathy eye than non-proliferative. Hard exudates. Hyperreflective spots more than 30 micron with backshadowing present in the outer retinal layers are suggestive of hard exudates, while hyperreflective spots more than 30 micron with backshadowing present in the inner retinal layers are suggestive of microaneurysm. Intravitreal injection of steroid may be more effective in reducing hard exudates in the patient with diabetic macular edema compared to anti-VEGF, especially when exudates are subfoveal. Intraretinal cystoid spaces. Cysts in the outer nuclear layer can damage the photoreceptor and disrupt the IS-OS junction, so affecting visual acuity permanently. The cysts have been classified as small 100 micron, medium 100 to 200 micron, and large 200 and more. Large cysts are associated with poor visual prognosis. Size of the cyst is correlated with the extent of macular ischemia. Cysts 200 micron in the outer nuclear layer damaging the photoreceptor and disrupting the ISOS junction lead to irreversible visual damage to poor visual prognosis. Pearl necklace sign. It is a hyperreflective dot in the form of a ring around the inner wall of the cystoid spaces seen on OCT. It is a precursor to development of hard exudate in exudative maculopathies as diabetic macular edema. Subfoveal location of this sign may cause irreversible photoreceptor damage, causing poor visual outcome. Bridging retinal process, seen between cystic cavities and associated with good visual acuity after treatment. They are the process of the molar and bipolar cells that transmit visual impulses to the optic nerve axons. Their absence leads to poor prognosis post-treatment with development of foveal atrophy. Disorganization of the retinal inner layer, DRIL. DRIL is defined as the inability to distinguish between the ganglion cell layer, inner plexiform layer, inner nuclear layer, and outer plexiform layer. Disorganization of these layers leads to abnormal visual processing. It is associated with or without centrally involved macular edema. It has been correlated with macular capillary non-perfusion and size of the face. In the picture, we can find that the first picture we have resolved edema and no DRIL, so we have good vision. In the other picture, the below one, resolved edema with DRIL, so we have poor vision. The other pictures, we have current edema and no DRIL, so we have good vision, and current edema with DRIL, poor vision. So there is always, once there is DRIL, there is poor vision. It is measured on OCT scan by looking at the central 10 millimeter retinal zone. This organization of more than 50 or 500 microns of this area is considered significant and is associated with worse visual prognosis in eyes with edema or resolved edema. 300 micron increase in DRIL during 4 months predicted a decline of visual acuity by 1 line. It can be used as a potential clinical marker of visual function to test potential therapies for diabetic patients. Photoreceptor outer segment, PROS. It is the lens between the inner and outer segment junction and the RPE. Studies showed that PROS lens correlated better than macular thickness at the fovea with visual acuity. Oskaya and colleagues have shown that PROS length was significantly less in eyes with diabetic retinopathy or diabetic macular edema compared to healthy subjects. External limiting membrane and ellipsoid zone integrity. Studies shows that eyes with intact ISOS junction have better visual gain post-treatment. Patients with long-standing diabetic macular edema may demonstrate loss of external limiting membrane and ellipsoid zone focally and in a diffuse manner. Extensive external limiting membrane disruption is the strongest OCT biomarker to predict anti-VEGF resistance, followed by tractional epiretinal membrane, ellipsoid zone disruption, and DRIL. Subfoveal neurosensory detachment. Subfoveal serous retinal detachment in subjects with diabetic macular edema is 15 to 30%. Presence of subretinal fluid in the diabetic macular edema is an important OCT biomarker. The role of subretinal fluid in final visual and anatomical outcome is still confusing. Results from RESTORE study and post-hoc analysis from RISE and RIDE study proved protective role of subretinal fluid. Eyes with subretinal fluid have shown increased interleukin-6 levels, signifying active inflammation with good response to steroid injection. Retinal thickness. Central subfoveal thickness is neither prognostic nor predictive of the final outcome. Subfoveal choroidal thickness. Patients with greater choroidal thickness have an intact choriocapillaris and less ischemic outer retina. Thus, photoreceptor function are well preserved. Taut posterior hyaloid membrane. Posterior hyaloid may form a sheet along the posterior pole, resulting in tractional force and mechanical retinal distortion. This is termed taut posterior hyaloid membrane. It is responsible for refractory macular edema. Patients with taut posterior hyaloid membrane benefit from pars plana vitrectomy and removal of the taut hyaloid. Case 1, female patient 65 years, diabetic from 13 years, complaining of drop of vision, best corrected visual acuity was 0.4, OCT was done, revealing subfoveal cystic spaces, intact ISOS junction, partial PVD, bridging retinal process, and hyperreflective retinal foci. Case 2, male patient 58 years with a history of diabetes 20 years, best corrected visual acuity was 0.2, his OCT revealed subfoveal hard exudate, subretinal fluid, choroidal hyperreflective foci, subfoveal cystic spaces, bridging retinal process, and hyperreflective retinal foci. Case 3, a male patient 68 years with best corrected visual acuity 0.1 shows drill. Automated identification and quantification of diabetic macular edema biomarkers. There is a great interest in using AI technologies for automated analysis of the previously mentioned biomarkers to inform disease progression, prognosis, and the treatment decision. The aim is to improve patient care in the clinical routine using so-called clinical decision support system with personalized treatment algorithm. The AI is used for staging and classification, lesion analysis, functional assessment, personalized treatment planning, progression prediction, and decision and screening. However, despite the significant advancement in AI algorithm for diagnosing and managing diabetic retinopathy, diabetic macular edema, challenges related to real-world effectiveness, regulating compliance, and privacy concern persist. And the other topic is retinal ischemic cascade. Although the photoreceptors are nourished by the choroid, the rest of the retina receive blood supply from the central retinal artery, which branches upon entering the retina into 3 plexuses: superficial, intermediate, and deep. Superficial capillary plexus lie in the ganglion cell layer and the optic nerve fiber layer, and include veins, arteriole, and capillaries. The intermediate capillary plexus and the deep capillary plexus consist mainly of capillaries. The intermediate capillary plexus found at the boundary between the inner nuclear layer and the inner plexiform, where at the deep capillary plexus in the outer plexiform layer near the photoreceptor synaptic terminal. Deep capillary plexus is more susceptible to ischemia due to its location in the watershed zone and with limited oxygen supply. Inner nuclear layer is the highest layer vulnerable to ischemia due to its high metabolic activity, with decreased oxygen saturation being supplied by the middle and deep capillary plexus. Paracentral acute middle maculopathy, PAM. PAM is a hyperreflective lesion in the inner nuclear layer due to ischemia of the intermediate and deep capillary plexus. Patient complains of paracentral scotoma with normal near vision. Etiology of PAM, idiopathic, secondary to systemic disease and diabetes, sickle cell anemia, migraine, giant cell arteritis, local disease and retinal vein occlusion, artery occlusion, retinal vasculitis, Purchase retinopathy, and blunt eye trauma. Diagnosis: it needs multimodal imaging. The OCT reveals hyperreflective lesion in the inner nuclear layer. On FAS OCT, whitening and edema at the level of the deep capillary plexus. OCT angio, flow void area at the level of the deep capillary plexus. Fundus fluorescein angiography. No non-perfusion can be detected as fundus fluorescein angiography delineate only the superficial plexus, so PAM lesions can be missed. Fundus autofluorescence, hypofluorescent lesion corresponding to the area of PAM. Types of PAM by on-FAS OCT. We have the arteriolar, globular, and fern-like perivenular. The arteriolar, there is hyperreflectivity in the region of the major arteriolar occlusion. Globular, if the occlusion is at the level of the capillaries. Fern-like perivenular, mildest form occur with vein occlusion. The ischemic cascade in the macula. The mildest form of central retinal vein occlusion or central retinal artery occlusion are associated with perivenular PAM, but these disorders can progress laterally to diffuse globular PAM, which is ischemia at the level of the deep capillary plexus. These lesions either progress to retinal atrophy, or if the insult ischemia continue, these lesions ascend anteriorly to involve the inner retina at the level of the superficial capillary plexus, ending in arteriolar occlusion. PAM lesions persist for weeks, then ultimately atrophy. After the acute phase, contraction of the focal infarction of the inner nuclear layer is often accompanied by compensatory upward expansion of the outer nuclear layer in the plane of the outer plexiform, leading to the wavy appearance of the middle retinal layer on B-scan known as ripple lesions. Retinal ischemic perivascular lesion, ripple. Ripple is a biomarker for cardiovascular disease, as ischemic heart disease, AF, hypertension. It is permanent and focal. If ripples are identified in an individual without known cardiovascular disease on routine examination by ophthalmologists, this suggests that cardiac evaluation should be needed. It is permanent focal inner nuclear layer thinning with associated outer nuclear layer expansion and outer plexiform layer displacement. It is always found between 2 vessels. Acute macular neuroretinitis, AMN. AMN is a hyperreflective band affecting the junction of the outer plexiform, outer nuclear, with disruption of the ellipsoid zone. In comparison to the AMN, it is deeper than the PAM, which affect mainly the inner nuclear and inner plexiform. The primary insult in AMN is thought to be involved the inner choroid and deep capillary plexus. In contrast to PAM, its primary insult is in the deep capillary plexus and intermediate capillary plexus. AMN tend to affect patients who are younger, below 30, mostly females, while PAM affect older patients above 50 male with vasculopathic risk factors. Scher's pathophysiologic mechanism may be sudden change in blood pressure that overcome the ability of the deep capillary plexus or choriocapillaris to auto-regulate such changes. Patient with AMN presents with central or paracentral scotoma as PAM, but with mild decrease in visual acuity and metamorphopsia, these symptoms may last for weeks or months. Risk factors including infection or febrile illness, COVID infection and vaccination, oral contraceptive pills, intravitreal anti-VEGF injection, caffeine, and prothrombin associated with antiphospholipid antibodies. Diagnosis: fundus photography may not detect early lesion. Visible lesions are reddish brown or orange with teardrop shape pointing toward the fovea. Amsler chart typically shows a corresponding scotoma. Visual field may reveal the scotoma. Fundus fluorescein angiography are usually normal. OCT revealed hyperreflective band affecting the junction of the outer plexiform, outer nuclear, with disruption of the ellipsoid zone. Management: rule out systemic risk factor as diabetes, hypertension, cardiac ischemic disease. In case of diffuse disease, carotid disease and giant cell arthritis should be excluded. Case 4, a 34-year-old female, came complaining of defective vision, her right paracentral scotoma, no history of diabetes or hypertension. On examination, anterior segment was free. Fundus examination showed no abnormality. OCT was done revealing right AMN, denoting ischemia. Patient was advised to regular monitor her blood pressure, blood sugar, and cardiac consultation and follow-up. Case 5, a male patient, 58 years old, came complaining of defective vision OU. Diabetes from 7 years, diabetic from 7 years, not hypertensive. Best corrected visual acuity was 0.7 OD and 0.5 OS. On examination, he has left nuclear cataract, but the right eye doesn't have any significant cataract. Fundus examination was normal. OCT was done revealing right ripple. When OCT angio was done, there is ischemia in the deep capillary plexus. Take-home message: biomarkers provide an in vivo assessment of the health of the retina and choroid non-invasively. They play an important role in deciding the treatment protocol as well as the prognostic outcome. Thank you.
شكرا دكتوره لبنى على البرزنتيشن الجميله دي عن الاو سي تي في الدايابيتيك ريتينوباثي. دلوقتي الدكتوره منى عبد الفتاح، او سي تي ان ايج ريليتد ماكيولار ديجنريشن.
طيب وانا اتمنى ان انتوا تبقوا لسه عندكم صحه تسمعوا حاجه كمان، بس الميزه ان انا البرزنتيشن بتاعتي قريبه قوي من البرزنتيشن بتاع الدكتوره لبنى، وفي حاجات كتيره قوي متشابهه لان البروسيس تقريبا واحده. الاول نحاول نفتكر كده الايم دي. طبعا كلنا عارفين ان AMD ده degenerative disease affecting the macular associated with many factors like inflammation, oxidation damage, aging, genetic predisposition, and environmental factor. When you see AMD, when you diagnose AMD, you see drusen, reticular drusen, retinal pigment epithelial atrophy, vascular changes of the outer retina, choroid thinning, loss of choriocapillaries. We can classify it to no apparent aging changes, normal aging changes, and early AMD, intermediate AMD, and late AMD. New vascular AMD is characterized by growth of abnormal choroidal vessels breaking through the RPE through the proximal brain to go into the subretinal pigment epithelial space. These vessels are also defined as macular neovascularization and can further expand beyond the RPE into the subretinal and the intraretinal layer. It can be classified into 3 types: the sub-RPE types, the occult one, the subretinal above the RPE, the classic one, and the intraretinal one, the retinal angiomatous proliferation. Exudation بيكون نتيجة immaturity of these vessels with and result in fluid accumulation in different layers corresponding to macular neovascular membrane extension and the ability of the retinal tissue to solve it. البايوماركر زي ما دكتوره لبنى شرحتها من شويه ان هي عباره عن ساينز احنا بنشوفها في الاو سي تي بتخلينا نفكر كده هو البروجنوسيس بتاع العيان ده ماشي في انهي اتجاه، هل هو اصلا يستحق ان هو يتحقن ولا يعني ممكن يتحقن ونشوف، ولا هو فعلا هيبقى محتاج انه يتحقن وهيبقى فيه جود بروجنوسيس. الاو سي تي بيزد بايوماركرز سنترال ريتينال سيكنس زي ما قلت لكم هيبقى في حاجات كتير متشابهه، retinal distribution of the fluid, structural alternation like drusen and its volume, reticular pseudodrusen, photoreceptor area integrity, hyperreflective dot, outer retinal tubulation, subretinal hyperreflective material, RBE tear, in vitro retinal interface adhesion and traction, choroid sub-RBE, hyperreflective column, pre-choroidal cleft, choroidal thickness and volume, and vascular index. Let's talk about each point in details. The central retinal thickness, as Dr. Lubna said before, it was in the old studies the first and the most common biomarkers. But in the old studies, they said the fluctuation in the retinal thickness because of the activity. But new studies said the parameter is not accurate. Retinal distribution fluid, the intraretinal fluid, subretinal fluid, and RPE detachment. Intraretinal cystoid fluid also we listen to it with دكتورة لبنى نفس القصة كده برضه، هو ان احنا بنتكلم على ان في cystoid spaces، الcystoid spaces دي اهم بايوماركرز في القصة كلها. انت تقلل الcystoid spaces الفيجوال اكتيفيتي الفيجوال acuity will be fine. subretinal fluid الستادي بتقول ان هي ممكن تكون العيان بيبقى معاه higher visual outcome and lower rates of atrophy, as some studies suggest that the subretinal fluid might protect the retinal photoreceptors from potential toxicity related to direct contact with the underlying diseased RPE. لكن لما subretinal fluid يبقى موجود معاها intraretinal cystoid أو pigment epithelial detachment ده بيبقى معاها على طول negative effect on visual acuity. السبريتينال RPE fluid برضو بتتكلم على انه لما تكون معاها intraretinal cystoid او subretinal cystoid هيبقى الافكت على الفيجوال اكيوتي is more، وطبعا لما بنلاقيها بنحتاج more intravitreal injection. structure OCT biomarkers retinal features زي ما اتفقنا ان الاي ام دي اكتر حاجه بنشوفها في الدروزن، وبالتالي احنا بنبص على الدروزن. الدروزن بتتقسم من small types اللي هو أقل من 63 مايكرون intermediate لغاية 124 and the larger one more than 125. Although increasing the macular drusen is a risk factor for AMD progression, we can't consider it as a progression biomarker on its own. Some studies suggest that the internal drusen reflectivity, particularly the presence of hyperreflective core, is associated with increased risk of progression to late stage, as well as the softer drusen. reticular pseudodrusen هي شبه الدروزن بس مكانها مختلف، بيبقى فوق الار بي اي وشكلها بيبقى زي المثلث. بيقولوا ان هي بتحول من لما تلاقيها على طول فكر ان الانترميديت اي ام دي ده هيتحول بسرعه لليت اي ام دي. الفوتوريسبتورز ليها انتجريتي برضو شفناها في الدايابيتك ان هي لما بتاثر لنا على الفيجوال اكت اللي هي الاكسترنال ليميتنج ممبرين ellipsoid zone and interdigitation zone. The disruption of the foveal ellipsoid zone and the external limiting membrane associated with compromised best corrected visual acuity at baseline and after anti-VEGF. Some studies say that after anti-VEGF, some external limiting membrane can be restored, and of course, it will cause a better final best corrected visual acuity. Progression بقى of the atrophy. القصة دي جميلة جدا. هو المفروض ان هو بيتكلموا على ان هي بتمشي كل layers تقل شوية، فهنمشي من incomplete outer retinal atrophy اللي هي C1 هتلاقوا ان الار بي اي كويس، الاكسترنال ليميتنج ممبرين كويسة، بس ابتدى يحصل فيه disruption في الellipsoid زون وابسنت في الانتروديجيتيشن زون وفي شوية سيننج في الاوتر ريتنا. نخش بقى على الليفل اللي بعده اللي هو D1 اللي هي complete outer retinal atrophy. هتلاقوا برضو الار بي اي تمام، بس الاكسترنال ليميتنج الاليبسويد زون والانترديجيتيشن زون افكتد وفي سيفير سيننج في الاوتر ريتنا. بعدين زدنا شويه كمان بقى معانا حاجه اسمها incomplete RB and outer retinal atrophy. طبعا انا ما بعرفش انطقها لانها ايرويا فحاجه صعبه بالنسبه لي. فهتلاقوا فيها inhomogeneous hypertransmission region, interrupted RPE, overlying photoreceptors degeneration, ومفيش RPE تاني. نخش على اللي بعدها السيرورة. هتلاقوا بقى ان في هايبر ترانسميشن ريجون بقى 250 اكتر من 250 مايكرون، وطبعا الار بي اي اللي فوقيه مش موجود، عشان كده بيحصل ترانسميشن لللايت. الاوفرلاين فوتوريسبتور ديجنريشن ونو ار بي اي تاني. هايبر ريفلكتيف دوتس تقريبا شبه اللي هي موجوده في الدايابيتك. وجودها بيدل من الاول كده لو لقينا عيان عنده سي ام في وعنده دوتس كتير نفكر على طول ان هو الفيجوال اكتيف بتاعته at baseline is poor. Non-responder patient shows persistent of high number of hyperreflective dots and vice versa. في حاجة بقى لسه قايلها امبارح اسمها دروس الأوس. دي حاجة بتقول إن هو less well-defined hyperreflective material extending from the top of the drusen into the overlying outer nuclear layer and external limit. هي الفرق ما بينها وما بين التانية إن دي بتبقى فوق الدروزن على طول وآخرها الأوتر نيوكلير لاير. الهايبرريفلكتيف التانية بتبقى منتشرة في كل طبقات الريتين. تمام؟ هي consider a sign of drusen regression and progression to advanced AMD, especially geographic atrophy. Outer retinal tubulation, the hyperreflective structure surrounded by hyperreflective band correlated with external limiting membrane and photoreceptors. There are two types, closed one and open one. The closed one, when they are 360-degree well-defined hyperreflective border. Of course, the open one doesn't have the 360-degree. Outer retinal tubulation can be considered as rearrangement of photoreceptors as a consequence of retinal injury, and their presence has been associated with worse visual prognosis. Subretinal hyperreflective material. It is a hyperreflective material located between neurosens retina and the RPE. ممكن تبقى fluid, fibrin, blood, scar, macular neovascularization. The baseline SHRM characterized as layered، يعني هي شكلها لو في مثلا layered appearance, hyperreflective spots, separation of the outer retina, large size، كل ده بيعتبر negative impact on the subsequent visual acuity. واحنا بنحقن لقينا ان الحته دي الهايبر ريفلكتيفيتي بتاعتها ابتدت تقل، ده good sign. Retinal pigment epithelial tail, also known as RPE ribs, represent the distribution of the RPE monolayer. It will known a complication of neovascular AMD. ممكن تحصل لوحدها، ممكن تحصل بعد intravitreal injection، ممكن تحصل بعد الفوتودايناميك ثيرابي. الهايت على البيس diameter ratio والirregularity اللي فيها this is a good predictor for الاوكيرنس بتاعتها. يعني هما بيقولوا لو الهايت عالي والبيس diameter قليل هيبقى فيه شد جامد فممكن تقطع، او ان هي لو شالوا وبرضه البيس diameter بقى واسع برضه ممكن تقطع. It has a negative effect on visual acuity when involved fovea due to thinning of nuclear layer at the area devoid of RPE. Vitreoretinal interface alternation. الادهيجن هو عباره عن elevation of the cortical vitreous above the retina، بس بيبقى لسه ماسك في 3 ملم وما بيحصلش فيه اي changes في الفوفيال surface. المفروض ان هو بيقولوا ان النيوفاسكولار AMD as an exudative fibrotic and proliferative event makes the vitreoretinal adhesion stronger and stabler to the retinal surface. Study revealed it's a present increasing need to have higher number of intravitreal injection. طبعا مارلين هتنبسط علشان ايه نحقن كتير. التراكشن بقى بيعتبر progression للادهيجن، بالتالي هيحصل فيه distortion of the foveal surface. التراكتيف action on the macular surface could lead to development of chronic inflammation. تخيلوا حاجه شاده من فوق وحاجه فبتوسع الطريق للممبرين انه ينتشر ويطلع فلويد زي ما هو عايز. Also, it reduces the functional and morphological improvement and require more injection in a Brunetta protocol. Studies suggest its removal cause more response to anti-VEGF. Choroidal feature. Sub-RPE hyperreflective column. It's a narrow column of hyperreflectivity beneath the RPE. It considered a sign of weakened or cracked RPE layer where fluid, blood, and all vessels can more easily break into the subretinal space. The big choroidal cleft هي تلاقوها كتيرة قوي عشان قعدت اتناقش مع دكتورة لبنى فيها هي ليه protective mechanism. خلينا نبدأ. It is outwardly bowed hyperreflective cavities between the deeper fibrous component and the underlying hyperreflective choroid. This multi-layered pigment epithelial detachment is due to retractive and exudative force of the neovascular membrane. If it is present in early 6 months, it has a negative effect on visual acuity, but if it present later, it has a protective effect against involutional and the geographic atrophy, as it provides oxygenation or nutritional support to the outer retinal layer and the RPE. So patients keep good visual acuity. It has a lower risk of developing high-grade RPE tear due to the stabilizing effect of the fibrovascular tissue complex that fills the sub-RPE space and anchors the pigment epithelial detachment to the underlying cross-membrane. Choroidal thickness. The thickness of the choroid doesn't affect visual acuity, but it is just a biomarker of different causes of macular neovascular membrane. As in neovascular AMD, there is a thin choroidal layer, unlike complicated CSR or pachychoroid neovasculopathy, which has a thick choroid. هما ما بقوش يعتمدوا على الكرويدال سيكنس على الاقل في الاي ام دي، يعني احنا مش بنتكلم على اوفيايتس دلوقتي، بس هما شايفين ان الكرويدال فاسكولار اندكس هو يعني اكتر sensitivity. والكرويدال فاسكولار اندكس ده بيعملوا proportion of vascular area، يعني يشوفوا الفيسلز على المساحه اللي هو السكان بيعملها. It is more accurate than the choroidal thickness, which affected by the circadian rhythm and intraocular pressure. برضو شايفين ان هو لما بنقل الاندكس ده بيقل، ده بيخلينا نفكر ان ممكن يحصل AMD. And research suggests the hypoperfusion of the choroid cause development of the AMD and neovascularization. This table for summarization. يعني لو حابين تاخدوا صورة يعني براحتكم، مش هيسيب مش مشكلة. ايوه كده شفتكم كلكم صورتوا تمام. طيب في حد يحب يعلق على السلايد دي؟ اتفضل يا خالد. تمام، ده اللي خالد قاله. و what we did now is what the AI programs wants to do, trying to do. خلاص. فال AI and biomarker. As we are in the era of the AI and its contribution in different fields, nowadays different studies uses AI program to collect different kind of biomarker. اللي احنا قريناها كلها وقاعدين نسمعها من الصبح دي اللي هي structure biomarker. في حاجة تانية اسمها functional biomarker اللي هي الفيجوال acuity, dark adaptation, contrast sensitivity، وهم لقوا ان الحاجات دي بتتأثر قبل حتى ما يبان ال AMD. ولقوا ان في حاجه اسمها blood and plasma biomarkers، ان العيانين اللي هم ناويين يجي لهم AMD بيبقى عندهم السيري اكتيف بروتين بيبقى عالي، الهاي density lipoprotein بيبقى عاليه، برضه الكوليسترول. and the more recent biomarker are the genetic one. كل الكلام ده بيحاولوا يحطوه في برامج عندهم علشان يجمعوها ويشوفوا predict who is going to have AMD and the progression of the disease and to personalize the treatment of the protocol. And thank you.
شكرا دكتوره منى على البرزنتيشن الجميله دي. شكرا. في اي اسئله؟ ماشي، شكرا.